Hello everyone, I hope you can hear me. We'll wait a little bit more for anyone else who would like to join us, and then we'll start. Okay, I see that more people are here. Last time, which was a long time ago, unfortunately, I think we talked about antibiotics and urinary tract infections, right? It wasn't something else. We talked about asthma, COPD, and then the next exercise was UTI and antibiotics, which means that we have one more exercise left, which is today's exercise, which is going to be pretty short, about pain and anxiety treatment and the different drugs and some characteristics about these drugs that are used in these conditions. And then we suggest we do the online colloquium on the 29th of December, if that is okay with you, at 4 p.m. Bulgarian time, so that we don't lose any exercises after the vacation. The 29th is Wednesday. I know it's part of your holidays, but it's only going to take 40 minutes or 45 minutes at the most. So this is, I think, better for your other remaining exercises, so we can take them all. And then after the vacation, we'll continue with the second part. And after that, we'll see what is going to happen with the exam session, whether it's going to start at the planned time or whether if it's going to be a little bit later. Okay, so if you don't have any questions, I think we can start with today's exercise. And again, if you cannot see the presentation or if you cannot hear me well, please someone call me or just use your microphone to inform me, because I'm not going to be looking at the chat. Okay. So the rational drug therapy of pain and anxiety is today's topic, as I told you. First of all, let's start with pain. Pain has different definitions, but I decided to give you this definition by the International Society of Pain. And according to this society, it has following definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So the damage actually can be potential or actual. What is acute pain? So pain can be acute or chronic, and again, according to the different definitions, the period when we say the pain is acute and when we say it is chronic is a little bit different. Acute pain is usually, of course, of a shorter duration. It's something protective and usually has an identifiable cause, and it has most of the time limited tissue damage or emotional response, unlike the chronic pain. It eventually resolves with or without treatment after the injured area heals. A chronic pain is, according to this definition, pain that lasts longer than 6 months, and it can have a constant or a recurring characteristic with mild to severe intensity. So it can be mild, it can be moderate, or even severe, depending on the cause. It does not always have an identifiable cause, so chronic pain is, that's why, hard to treat and hard to find its cause, and it usually leads to great personal and emotional suffering because of the time it takes for this pain to heal. There are, of course, such pains that there is no 100% cure, so these patients really lead a very suffering life. Examples of chronic pain are, for example, pain due to arthritic problems, headache, peripheral neuropathy, nociceptive pain is one of the three main types of pain. So this is another classification, and it is divided into somatic or visceral. Somatic is something that is more superficial and it comes from the musculoskeletal system. And visceral pain is a pain that comes from the internal organs, and its localization is harder to identify. Then the second very important class of pain, neuropathic pain, can be due to diabetic neuropathy or fibromyalgia. And then usually there is a third class of pain, which can be combined into functional and psychosomatic pain, which is another smaller group. But during the exam, and sometimes even in the colloquiums, the two must-know types of pain are the nociceptive pain and the neuropathic pain, and the third class of pain is either psychosomatic, or it can be also due to some infectious cause. So usually the third group is a group that combines the remaining types of pain. But the two most important are nociceptive and neuropathic. Here, I think you already have seen it. According to this classification, chronic pain is defined as a pain that lasts longer than 3 months, which is different than our definition. But I just wanted to show you that there are also other definitions for acute and chronic pain. Also, there are other types of pain. We said that the nociceptive pain can be divided into also visceral type of pain, which comes from the viscera or from the internal organs. And as an example, we can give, for example, stomach pain, which the visceral type is located in the middle epigastrium, but the parietal type is actually not quite there. It can be in the left upper quadrant or again in the middle epigastrium. But there is also a very interesting phenomenon, and this is called referred pain, when actually the main problem is in a completely different area, but the pain that is felt is in another area, like here with this example about the stomach. So if the problem is in the stomach, let's say gastric tumor or gastritis or something else that is related to the stomach, the referred pain can be felt actually around the shoulders. And this goes also with the appendix, gallbladder, especially the gallbladder and pancreas. They have also different syndromes, first described by the man who actually named and gave his or her name to these syndromes. For example, the pancreas can have a referred pain in the back or the left shoulder, and the gallbladder in the right subscapular area. So these are all examples of referred pain. Here is again another figure showing you the different classifications. So we have nociceptive, as we talked about, one of the main types of pain. Osteoarthritis, gout can be such examples of nociceptive pain. The second main type, we said that it's the neuropathic pain in diabetic neuropathy, peripheral neuropathy, and the third type, we said that it's combines several other types like sensory hypersensitivity, and here we have fibromyalgia as an example. Here again you see yet another classification. The two nociceptive and neuropathic do not change, but the third type here, it's called inflammatory, which also includes pain that is related to tissue inflammation due to different reasons, and hypersensitivity, which also includes again fibromyalgia. Another thing that can get asked in the exam or in the colloquium is about the mechanisms of pain. So in nociceptive pain, we have somatic and visceral. We said that the somatic is better localized, and the reason behind this is that the A delta fibers are involved in the sensation of this pain. And as you know, there are three types of fibers, three types of neurons, and they are A, B, and C. And this classification is based on the level of myelination, of how much myelin there is on the fiber itself. And the A fibers actually the best and the most myelinated, so the signals travel the fastest in this type of A fiber. B is in the middle, and C is actually the fiber with the least amount of myelination. That's why the signals within the C fibers are the slowest, and also it's harder to localize this type of pain, and it again comes from the internal organs, so that's why it can be a little bit longer lasting with a sensation like pressure, or it can be also due to some cramps, for example, whereas in somatic pain, it can be due to a superficial laceration, burns, stomatitis, otitis media. So they're very well localized and they have a stabbing or sharp sensation. And neuropathic pain is actually a pain that is radiating depending on the neurons that innervate a specific zone. Let's say in trigeminal neuralgia, we can have neuropathic pain. In peripheral neuropathy due to diabetes or HIV can also be an example of neuropathic pain. And also in limb amputation, patients also feel a very specific type of pain, which is also an example of neuropathic pain. This type of pain is called phantom pain, and they feel pain in the amputation where in the limb where the amputation has happened. So the missing part of their limb hurts them, which is interesting, but this is the type of pain that is also a neuropathic pain. So how do we manage pain? First of all, we need to classify this pain according to its severity. So it can be minor pain, it can be moderate pain or severe pain, and because it's not something objective like blood pressure or a heart rate that can be measured by the physician or by the healthcare professional, you need to ask the patient to make an assessment of the pain. There are special types of charts that help the patients better describe their pain. But if you don't have such a chart, you can just ask them from 0 to 10 how much they give as a score to their pain. Again, this here is another example with the different severity of pain, and here you see, for example, let's say if it's severity level 3, then it can be due to, let's say, an accidental cut or a blow to the nose causing bloody nose, or let's say a severity 9, where it is described as excruciating or unbearable pain. This can be due to throat cancer, let's say, which is really severe pain. If it is 7, 8, 9, or 10, or severe pain, it means that this patient cannot actually function normally due to the debilitating pain. In terms of treatment, of course, we have non-pharmacological approaches, including different types of mind-body therapy, massage, acupuncture, physical therapy, or even transcutaneous electrical nerve stimulator or TENS. What about the pharmacological approach? So this is our topic. First of all, if you remember from the asthma exercise, I told you that there are several things by the WHO, and these are also implemented in the clinical pharmacology classes that are taught at our university. And this is also the reason why they get asked in the exam, are about the different steps and the different stepwise strategies. So from the asthma, we had 4 steps in this strategy for treating asthma, if you remember. And also there is a similar approach in the treatment of pain, but with 3 steps. So step 1, 2, and 3. And the first step about the treatment of pain, I think most of you, if not all of you, have used something for pain at some point in your lives. It can be a headache or a sprain or something else. And the first step usually includes non-opioid drugs. What are non-opioid drugs? Well, the most commonly used non-opioids are actually the non-steroidal anti-inflammatory drugs like ketoprofen or acetylsalicylic acid, or ibuprofen also. Another is, of course, paracetamol, which is the international non-proprietary name, or the INN of acetaminophen. Acetaminophen is the name used in the US, but you should know that acetaminophen and paracetamol are one and the same thing. And also there are some other non-opioid options like capsaicin, which is a molecule that is derived actually from the chili peppers, which is interesting, and it is usually used as a local non-opioid analgesic, like creams or gels. And then we have the steroids and some other options that we're going to discuss in more detail. Also, in this first step, we can mention some drugs called adjuvants. So they're like helpers in addition to the main non-opioid drugs that are used for the treatment of pain. And the adjuvants include tricyclic antidepressants, or TCAs, which are commonly used for neuropathic pain, gabapentin, which is also a drug that is FDA approved for partial seizures. So it's an anti-epileptic drug, but it is also used sometimes in the treatment of pain, for example, in post-herpetic neuralgia, but also for other types of neuropathic pain. Even in diabetic neuropathy, gabapentin can be used. There is also lidocaine, of course, the local anesthetic that is very commonly used in minor surgical procedures, in, let's say, lacerations that come to the ER. And also, you know that lidocaine is a class 1B antiarrhythmic drug when it is given intravenously. So lidocaine can be used also to treat pain in post-herpetic neuralgia, or also in minor trauma during sports activities. So here is the stepwise approach when treating pain that I mentioned. So mild pain is step 1, non-opioids. Moderate pain is the next step, when we use weak opioids, and severe pain when we need to use strong opioids. So this is the simplest classification, and it is only 3 steps, and this can get asked in the exam, especially if it's an oral exam. Here is another classification that divides step 1 and 2 into another step, but this is not a classification that is preferred. And here yet another classification, again with the division of step 1 into 3 steps. Here you see step 1, paracetamol, non-steroidal anti-inflammatory drugs or NSAIDs, topicals, complementary treatments that we mentioned, like let's say corticosteroids, and then in step 2 we have the adjuvants like gabapentin or venlafaxine, which is also a drug that is used in depression because it's an SNRI. So serotonin, norepinephrine reuptake inhibitor, if you remember, and duloxetine is also an SNRI that is used for sometimes treatment of pain. Pregabalin is also similar to gabapentin. In step 3, we have the tricyclic antidepressants like Amitriptyline, which is also used sometimes in pain management, especially for post-herpetic neuralgia. Again, it can be used in migraine treatment also. And then step 4 and step 5, which is actually step 2 and step 3, we have the weak opioids like codeine and tramadol, and then in step 5 we have the strong opioids like morphine or fentanyl. Let's talk about the NSAIDs a little bit. So NSAIDs are actually drugs that are sold over the counter, so they're OTC drugs. Patients do not need prescriptions to get NSAIDs, but that doesn't mean that they're 100% safe if they're used for longer than 1 or 2 weeks, and sometimes even for shorter periods of time. In people who have gastrointestinal problems or renal problems, NSAIDs can actually aggravate these issues. In people with gastritis, they can cause pain or even gastrointestinal bleeding if there is a gastrointestinal ulcer in this patient. In people with renal failure, it can also further reduce the glomerular filtration rate. And also in people with renal and heart failure, it can cause, besides reduced glomerular filtration rate, also increased fluid retention, which can be very negative for their overall condition. And also NSAIDs, because they inhibit COX-1 and COX-2, if you remember, cyclooxygenase, this enzyme, it can cause platelet dysfunction due to thromboxane A2 inhibition. Some examples of NSAIDs, also we have COX-2 selective NSAIDs like celecoxib. We have meloxicam, also acetylsalicylic acid, and naproxen also is a very important NSAID to be aware of. And another thing that you should know, Tylenol is the trade name for paracetamol. And paracetamol is not an NSAID because it is not a non-steroid, yes, but it is actually a non-steroid, so it's not a steroid. This is what I mean, but actually paracetamol doesn't have anti-inflammatory effects, so that's why it's not an NSAID. It has antipyretic effects and it has analgesic effects, but paracetamol is not an NSAID. So this is something to keep in mind. Corticosteroids Sometimes pain can be due to edema, and this edema can cause compression, which can lead to visceral pain, and also the edema can be due to inflammation due to different reasons, let's say osteoarthritis or other types of arthritis. And in these types of pain, corticosteroid application can help reduce the edema and the inflammation, and this can lead to a reduction in pain also. But you should be especially careful if there is, let's say, knee pain with an edema around the knee. You should first rule out septic arthritis, because if you administer corticosteroids in septic arthritis, actually this can further disseminate the infection, because you know that corticosteroids are actually also immunosuppressive drugs. So in septic arthritis, they are usually due to bacteria. So instead of helping the patient, you are going to help the bacteria to do their job even better. So that's why in patients in whom you suspect an infection, especially a bacterial infection, you should not administer corticosteroids. You should first really make a diagnosis and be sure that the pain is not due to some bacterial infection. One of the reasons why dexamethasone is preferred over other corticosteroids is that it has the least amount of mineralocorticoid effect and the highest amount of anti-inflammatory effects, even when compared to methylprednisolone or cortisol or other corticosteroids. Okay, so again, in summary, first step, non-opioid. Second step, we have non-opioids, adjuvants, and weak opioids. And then for severe pain, we have the strong opioids, which you can see here. I like this figure, even though it's not of very high quality, but it shows you that we have strong opioids here, like morphine, Thermofoxin, Fentanyl. We have the partial agonists, which are very important, like buprenorphine, which are used sometimes for different reasons. Then we have the weak opioids, like oxycodone, hydrocodone, codeine, which are commonly used for also moderate chronic pain management. And here in this table, you can see the different important points for one of the most commonly used opioids, like morphine, because it has renally cleared metabolites, and it is used for moderate and most commonly severe pain. It should be avoided in patients with decreased creatinine clearance, because these metabolites can actually accumulate and cause toxic effects in this patient. And fentanyl, for example, has different forms of application. It can be used intravenously, but there are also fentanyl patches. And because it takes up to 48 hours to achieve a steady state, it can be used with patches for the treatment of chronic severe pain, let's say in patients with advanced cancer. This patch can be used with great potential. Meparidine, this is actually another name for petidine. It's similar to paracetamol in that it has different names in the US and in Europe. So meparidine and petidine, they are one and the same thing, and it can also be used in surgical clinics like vascular surgery or in gastrointestinal surgery patients, post-surgical patients also, and it is also renally cleared metabolite, so be careful in patients with a low creatinine clearance. This is another important, I think, point in when you are trying to convert or the dose or go from one opioid to another opioid. You should keep in mind that, for example, morphine has both oral formulations and intravenous formulations, and 1 milligram of IV morphine is equal to 3 milligrams of peroral morphine. And based on this information, you can assume that the bioavailability of morphine when it is given orally is actually around 33%, or let's say from 30 to 40%, because it can change in different persons. And another important thing is that fentanyl, 100 micrograms, so it's not milligrams, it's micrograms of fentanyl, patch is equal to 200 milligrams oral morphine. So this is an important point, because in the exam you can get asked the question, which is more effective and which is of higher potency. So potency and effectiveness are two different things. And about the question concerning the effectiveness of morphine and fentanyl, we can say that because both of them are actually strong opioids, in terms of effectiveness, maybe they're around equal effectiveness, but in terms of potency, which is different than effectiveness, potency describes the same effect, but a different dose. So fentanyl can achieve the same effect as morphine, but with a lower dose. That's why it's said that fentanyl is actually more potent than morphine. So this is another important question about morphine effectiveness and morphine potency when compared to fentanyl. This is true also for other drugs. They can be equally effective, but one drug can be more potent than the other. Here we have a clinical case, and such clinical cases you'll also have in the colloquium. Maybe not exactly the same, but different clinical cases, and you will have to explain how you are going to confirm your diagnosis, and you'll be asked to give 2 or 3 differential diagnoses, different exams that you're going to need to get into this diagnosis, and also different therapeutic options, like a drug class with a specific example, let's say an antibiotic from the cephalosporin group of antibiotics, let's say ceftriaxone or cefuroxime, let's say. You'll have to give reasons why you made this choice. And in this case, we have a 70-year-old male with end-stage renal disease on hemodialysis that presents with methicillin-resistant Staphylococcus aureus or MRSA or MRSA, bacteremia, and ankle pain after a fall. And an MRI of the ankle is negative, and he started on paracetamol and lidocaine patches, which results in adequate pain relief of the ankle, but he later develops neuropathic pain in both arms, and a CT scan of the cervical spine reveals a cervical abscess and osteomyelitis. So this abscess and osteomyelitis are probably due to the MRSA, because it's a highly resistant bacteria and very hard to treat. So the patient now has pain in his neck and desires pain relief, but refuses narcotics. So he doesn't like to get strong opioids because he doesn't want to get addicted. And how can this patient be managed? What can we do about his pain? Well, it's actually hard question. It's not only pharmacologic, but it has ethical issues too. We can have another try with higher doses of paracetamol, although we can actually cause hepatitis or hepatic damage if we use higher doses of paracetamol, or if this patient has been taking paracetamol for a long time. For neuropathic pain, you know that besides weak opioids like tramadol, we have the option to use gabapentin or other adjuvants. So this is another option, 100 milligrams of gabapentin at bedtime. And this can be increased twice daily after a couple of days. And this is one way to try to control this patient's pain. That being said, we should conclude that pain management is a comprehensive, patient-centered. So it's not a decision that you take only on your own. You should always inform your patient of your strategy. And also, you should try to listen to your patient's wishes. What kind of adverse effects should the patient expect? These are also things that sometimes patients really value, and that's why you need to know how to talk to them and how to explain to them the pluses and minuses of each therapy, or the pros and cons of each therapeutic strategy. PCA, this is patient-controlled analgesia. This is another thing that I wanted to show you. So this device is actually something that can be used in hospital settings and also in hospice or in different care facilities, and also sometimes at home even. What this device does is actually allows the patient to administer the dose of analgesia when the pain, according to this patient, is at its highest level. But it, of course, has some limits. The patient cannot administer a very high dose, which can be dangerous for the patient. But the drug can be controlled, the dose can be controlled in some limits by the patient. Because, at hospital settings, patients with chronic pain usually get prescribed a drug. Let's say every morning at 7 a.m. the patient gets tramadol or something at a specific dose, but sometimes the patient is feeling okay at 7 a.m. but has pain around 11 a.m. So this is an option for the patient to try to determine at what time he or she is going to get the dose of analgesia. Going to the next topic about anxiety disorders. I think from psychiatry, I believe you have started studying psychiatry this year. It's a very interesting subject, of course. And there is this great class of disorders called the anxiety disorders, which are divided into usually GAD, or generalized anxiety disorder, panic disorder, phobic disorder, PTSD or post-traumatic stress disorder, and obsessive compulsive disorder. If someone is interested in psychiatry or in anxiety disorders or other rare types of disorders, um, I suggest you get the DSM classification. I think there is DSM-5 now. It is a great textbook describing all sorts of classifications, even things that you can find interesting and strange sometimes, that such thing is even considered a disease. So the anxiety disorders are actually getting more and more common every day, and this is partly due to the way of life and the work that we are doing nowadays, like the jobs and the job characteristics. Also, the lives in big cities help in the etiology of the anxiety disorders. And that's why there are millions of people taking anxiolytics. What are first-line anxiolytics in the treatment of GAD? And this is also true for the other types of anxiety disorders, not just for the generalized anxiety disorder. First line, we have the SSRIs, and SSRIs are escitalopram, paroxetine, sertraline. These are very well-known drugs of the SSRI class, and SSRI means selective serotonin reuptake inhibitor, as you remember. They're pretty safe. So the therapeutic index is above the hundreds, which means that even if someone takes 100 tablets of SSRIs, probably it's not going to be lethal, which is great for these drugs. Unlike the older anxiolytics like the TCAs, which have a higher potential of toxicity. Another option are the Thermofoxin and Duloxetine, and these are the SNRIs. Actually, this is what I wanted to tell you. The serotonin norepinephrine reuptake inhibitors, which as a mechanism of action are very similar to the TCAs, because what the TCAs do is actually they inhibit the reuptake of serotonin and norepinephrine. The bad thing about the SSRIs and SNRIs is that they take a long time before they start working. So they take 2 or 3 weeks of continual therapy before they start working. And this is something that you need to inform your patient about, because your patient can just decide to stop taking them after 1 or 2 weeks when they see no effect at all, and this is of course something that is expected. And unlike the benzodiazepines, which are second line, the benzodiazepines, they start working right away. They're very effective, but they have a very negative adverse effect, and this is that dependency develops very quickly. After 2 or 3 weeks, patients usually get dependent, and it's very hard for them to stop their therapy with benzodiazepines. One thing that some psychiatrists decide to do is for the first 2 to 3 weeks to combine an SSRI like paroxetine, 20 milligrams twice daily, with a benzodiazepine, which is actually a very clever strategy, because the benzodiazepines are going to be effective right away, and then after they're stopped, the idea is for the SSRIs to kick in and to start acting. This is one strategy that can be used also to reduce the duration of benzodiazepine treatment. Another drug class as a second line are actually pregabalin, so some anxiolytics, or also TCAs like imipramine can be used as a second line treatment of GAD. And as you remember, pregabalin and imipramine can also be used in the treatment of pain, especially of chronic pain. Then we have, of course, other less commonly used drugs. Hydroxyzine is one of them, and hydroxyzine, as you know, it has effects on different neurotransmitters, including histamine, including dopamine receptors, and also it is a drug that can be used sometimes in patients with insomnia or with nausea due to their antihistaminic effects. It is also used in other conditions like motion sickness. Another drug is, again, buspirone. It is a drug that is used in generalized anxiety disorder. It is also administered orally, and again takes a little bit longer period of time, similar to the SSRIs, to start working. Here, maybe it's a good idea to mention the atypical antipsychotics, like quetiapine, risperidone, or olanzapine. When patients are taking quetiapine and risperidone, they can also get severe reactions in combination with other drugs, especially arrhythmias. And this is very true for quetiapine with chronic use. What are the adverse drug reactions of SSRIs and SNRIs? Well, anorexia, nausea, and vomiting, they are most common, and the most common reason for discontinuation, of course. But they are usually dissipated in a week. Patient can get diarrhea in up to 20% of cases due to increased serotonergic activity in the gut, because we said that they block the reuptake of serotonin selectively. Sexual dysfunction is very common. Sleep disturbances in patients who are taking SSRIs and SNRIs. Seizures, extrapyramidal symptoms, they are rare, but still a possibility. And this nice table here actually compares the different anxiolytics: SSRIs, benzodiazepines, TCAs, MAO inhibitors, the RIMAs, and anticonvulsants. And because the SSRIs are one of the safest drugs, they're of course first line, and we have the benzodiazepines, which are also safe, but they cause dependency after several weeks. But otherwise, they're much safer from the TCAs. And again, the therapeutic index is actually above 50, which means that even if the patient takes 50 tablets, which is not something very atypical in patients with anxiety disorders, they can also have depression and suicidal thoughts. So they're safe, but they cause dependency. The TCAs and MAO inhibitors and RIMA and anticonvulsants are not preferred because they have severe adverse reactions, and their therapeutic index is much lower than the SSRIs and benzodiazepines. So this is it for today. If you have any questions, you can ask them. Again, about the colloquium, I hope on the 29th at 4 p.m. It won't be a problem
Doctor,
for you. Yep.
Could I ask you something? In the topics of the colloquium would be everything that we have done up until now.
Yes.
Okay.
Yes.
And it would be like multiple questions and open questions.
So it's going to be both multiple questions, and as I told you, they're going to be cases, like clinical case scenarios, like the one I showed you. And at the end of this case, you are going to get asked a question like, what do you think is the diagnosis, or what is the differential diagnosis? And you should list like 2 or 3 diseases. And then another question can be, what kind of tests you are going to perform on this patient, like CT, MRI, blood tests, chest X-ray, EKG, these kind of things. And the third question can be, how are you going to treat this patient? By giving antiaggregants like ticagrelor, or anticoagulants like heparin, or maybe SSRIs like sertraline. So this can be like an example question and a couple of answers. Other questions can be true or false questions, asking you different things. And multiple choice questions, of course, but the most points you're going to get from the clinical cases, because they're going to take longer to answer. And also, you can use your textbooks, or I will also send you the presentations so far. As I told you, 1 week before the colloquium. You can also use them as preparation. If you have notes, also you can use your notes. And again, if you have any other questions, don't hesitate to contact me. This is my email. I would like to ask you to send me a personal email from your personal email, writing your name and group number, which is very important. So name and group number, name, family name, and group number, so I can respond you back with a unique code that you will use for registration for the platform for the online colloquium. This you can do today or tomorrow, before the 25th, hopefully, so that you can make a registration, and on the 29th you can just go online with your email and password, and then do your colloquium. And yeah, this is it. If you don't have any other questions, I wish you happy holidays. And again, you can contact me at this email, or my phone number. You can also call me.
Okay, doctor. Happy holidays. Thank you.
Okay, thank you. Bye bye.
Bye.
You are currently the only person in this conference.